Pam Taub. I'm a cardiologist and professor of medicine at UC San Diego. And I'm really delighted to have Dr. Michael Hollick and Dr. Joanne Manson join us today. They're both the world experts on vitamin D. Dr. Hollick is a pioneer in the space and professor of medicine at Boston University. He was the first to identify the major circulating form of vitamin D in human blood as 25-hydroxyvitamin D3 over the past 4 decades. He's led many of the studies demonstrating the benefits of vitamin D and is responsible for bringing vitamin D to the radar of healthcare professionals. Dr. Joanne Manson is another luminary in the field and a professor of medicine at Harvard Medical School. She's been involved in many landmark clinical trials that have changed our clinical practice, including the Harvard Nurses Health Study, the Women's Health Initiative, and most recently, the VITAL study. It's a pleasure to have you both here, and I'm looking forward to a very lively discussion. I'm going to start by asking Dr. Hollick a question. You have shown throughout your career that vitamin D has a variety of health benefits, ranging from being anti-cancer to improving blood sugar to enhancing immune response. Can you highlight some of these trials?
Sure. So we're now recognizing that vitamin D, of course, has to get activated, like you said, first in your liver to 25-hydroxyvitamin D, and then in your kidneys to 125-dihydroxyvitamin D. And originally, we realized that vitamin D is really important for your bone health. And so therefore, looking at receptors for 125-dihydroxyvitamin D, they were found in the intestine, bone, and kidney, which regulate calcium metabolism. But then we began to realize that basically every tissue and cell in your body has a vitamin D receptor. And obvious question is, why would they be there? And there's now a lot of evidence to suggest that immune cells, colon, breast, skin, many cells in your body can activate vitamin D locally. And we think that it does it for the purpose of regulating cellular growth and a variety of genes. And as a result, there are a multitude of association studies that have related vitamin D deficiency with increased risk for autoimmune disorders like type 1 diabetes, multiple sclerosis, rheumatoid arthritis, increased risk for cardiovascular disease, increased risk for neurocognitive dysfunction, and increased risk for infectious diseases, as well as some malignancies.
One of the things that has come up in many of these clinical trials is the biomarker by which we measure vitamin D. I'd love to get both of your comments on what is the best biomarker to measure vitamin D levels.
I mean, I don't think there's any debate about this. Is you only want to measure 25-hydroxyvitamin D. It's the major circulating form of vitamin D, and it's used worldwide by doctors to measure the vitamin D status of your patient. The active form of vitamin D gives you no insight into your vitamin D status. It's often normal or even elevated in a vitamin D deficient state because of secondary hyperparathyroidism. Only useful 125-dihydroxyvitamin D for inborn and acquired disorders in calcium and vitamin D metabolism.
Yes, I agree that there really isn't controversy about that point. There are some more recently discovered biomarkers and evidence that the free bioavailable and free 25-hydroxy-D may provide some additional information, but the research has been quite limited. And certainly from a clinical standpoint, it would be the serum 25-hydroxyvitamin D. That's the biomarker of vitamin D status.
Dr. Manson, you recently led a very important landmark clinical trial, the VITAL trial, and you showed that vitamin D supplementation did not reduce cardiovascular risk. But there were some other pearls from that trial on some benefits of vitamin D. Can you go over the trial with us?
So the vitamin D and omega-3 trial, VITAL, is a large-scale nationwide trial in the United States, including more than 25,000 men and women. And the primary endpoints were cancer and cardiovascular disease. we found no significant reduction in total invasive cancer, nor in total cardiovascular disease. However, we did see a strong signal for reduction in cancer death. We had a 17% reduction in cancer death that just missed being statistically significant. But when we accounted for cancer latency and looked at those who had been in the trial for at least 2 years, long enough to actually have an effect on cancer death, we did see a statistically significant 25% reduction. Now, the reason this was of particular interest is that several other randomized trials had suggested that there may be an effect of vitamin D supplementation on reducing cancer death. So we did a meta-analysis of 5 large-scale trials available looking at vitamin D supplementation and having information on cancer death. And the result in the meta-analysis was of a statistically significant 13% reduction in cancer death. And all but one of the trials showed that, the hazard ratio was on the side of benefit. Only one that was bolus dosing, very high doses, given monthly, given less frequently, did not show a clear reduction. And there has been increasing evidence that vitamin D given daily may be of greater biological benefit than vitamin D given in very, very high doses in a bolus form only once a week or once a month, or even less frequently. Some trials are testing bolus vitamin D even every 3 months or every 6 months.
In the VITAL trial, the average vitamin D level was around 30. Do you think we would have seen more of a benefit if we tricked people that were really vitamin D deficient, maybe levels less than 10, and then repleted them?
I think probably the benefits of vitamin D supplementation are greatest in those who are truly deficient. The problem is that it's not ethical to do a long-term trial in people who are known to be deficient, because half of them, or usually in most clinical trials, will be randomized to a placebo, and that means they will remain vitamin D deficient for 5 years or longer. For example, the median duration of the VITAL trial was 5.3 years. So usually when we do test for vitamin D and find that someone is deficient, we want to treat them on a relatively urgent basis and not wait 5 years to let them know the result of the trial. So what we did was a trial that was a usual risk population. Most of the trials in the United States do include people who on average have a 25 hydroxy vitamin D level close to 30 nanograms, but many of them still do have levels below 20. But when these levels aren't measured at baseline and you're not targeting those who are deficient, then it's reasonable to just try to get a broad, generalizable group of participants and see if the results do differ by baseline vitamin D status. We couldn't find strong evidence for that in VITAL, but I think that's because we did not have a very large number of people who were profoundly vitamin D deficient.
Any comments on that, Dr. Hollick, about what level you start with and the benefit you can achieve?
Yeah, I agree with Joanne completely. I mean, more than 50% of the VITAL participants were vitamin D sufficient. So you really have to ask the question, if you're vitamin D sufficient and you're now given vitamin D, is it going to have some additional health benefit? And are you going to be able to see that distinction? And as Dr. Manson said, she did not. And to me, that was not at all a surprise.
But I do want to say that the goal of the VITAL trial was not to determine whether we should treat vitamin D deficiency. We know vitamin D is essential to health, and we know it's important to avoid vitamin D deficiency. The key question was whether there is a benefit of increasing vitamin D intake, supplementation, beyond what is obtained in the usual US population with that type of baseline vitamin D blood level and getting on average maybe only 600, 400, 600, even less, maybe 400 IUs a day of vitamin D from various sources. The question was whether giving more would reduce risk. And I think that the randomized trials do help to answer those questions. But having a neutral result by no means negates the importance of vitamin D to human health. So I think it's really important that people understand that. Some of the disagreement may be about the amount of vitamin D we need in order to have optimal cardiovascular health or optimal reduction in cancer risk. And if anything, I do think the VITAL trial showed that more than usual intake of vitamin D is of benefit in reducing cancer death.
Great points. Let's talk about some clinically important areas where there is debate about vitamin D supplementation. One is statin intolerance. Dr. Hollick, what are your thoughts about giving patients who are statin intolerant vitamin D?
Yeah, statin, of course, can cause muscle aches and pains. And if you're vitamin D deficient, you can have osteomalacia, which causes aches and pains in your bones and muscles. And so there is some evidence that improving vitamin D status, making them vitamin D sufficient, they would be less prone to developing that complication.
We're actually looking at this in VITAL. So we're hoping to have the results published within maybe another few months. What we're looking at is people in the study who were new initiators of statins and reported muscle aches and pains as some of the symptoms associated with statins, and whether those who were randomized to vitamin D were less likely to develop these symptoms than those randomized to placebo. So we're in the process of analyzing the data and are preparing a manuscript.
Those are really important results that will also guide our clinical practice. Now let's shift to something that is on everyone's mind, which is COVID-19. There's a lot of data that shows low vitamin D levels are associated with patients who have more complications from COVID-19 or in the ICU. So what are both of your thoughts on supplementation with vitamin D for everyone? Because we all want to have less complications if we acquire COVID.
I think the research is promising, but not conclusive to date. And we're doing a randomized trial. I'll tell you more about the trial that we're doing, and we'll see, if it's addressing some of the, issues that Mike brings up.
We initiated studies almost immediately. We worked with Quest Diagnostics and looked at over 191,000 COVID positive patients throughout all 50 states, all ages, ethnicities, and latitudes, and showed that if you have a blood level of 25-hydroxyvitamin D of 20 compared to 34 nanograms per ml, that you had a 54% higher risk of acquiring the infection. We know that vitamin D does have an important role to play in immunomodulation, and that the COVID infection causes the cytokine storm. And the thinking is that the active form of vitamin D can help to regulate that, downregulate cytokines that are damaging and improve cytokines that can help. And so we've done a couple of studies. The first was in Iran with Dr. Magabouli, and showed that if we looked at patients coming into the hospital, over 200 patients, 74% that had serious infection, and looked at their baseline blood levels of 25-hydroxy-D and their outcomes, we showed that there was a significant decrease in morbidity and mortality. And in fact, those over the age of 40, there was more than a 50% reduced risk of dying of the infection simply by being vitamin D sufficient at the time they went into the hospital. We did a study at our hospital at Boston Medical Center and looked at patients coming into the hospital. We got their baseline blood level and then followed them for their morbidity and mortality. And again showed very significant differences. Those that were deficient had more significant morbidity and mortality. So we do believe that improving vitamin D status really throughout your life can help reduce risk of infections and COVID. But more importantly, patients that are going into the hospital, if nothing else, I think that they should be treated with vitamin D almost immediately.
Okay, so I just want to say that I agree with what Mike has said in terms of the correlation between low vitamin D status and increased risk of COVID, severity of COVID, hospitalization, adverse outcomes, including mortality. I think the evidence is really strong for that. Also, I totally agree with what he said about vitamin D. C, there are many biological mechanisms that have been shown for vitamin D to be important in boosting the boosting immune response, very, very important to the immune system, as well as tamping down inflammation, immune modulation, which are mechanisms very relevant to preventing severe COVID infection. However, correlation doesn't prove causation, as we say in epidemiology, which is why I know, Mike believes the randomized trials are very important. And there are many potential confounders. We know that people who have low vitamin D blood levels tend to be more likely to have these comorbidities that are linked to an increased risk of severe COVID illness, including diabetes, hypertension, cardiovascular disease, obesity. They're more likely to be in socioeconomic groups and racial ethnic groups that have had higher risks of severe COVID illness. And so there's a tremendous potential for confounding. That said, during a pandemic, if anything, we would want to err on the side of encouraging more intake of vitamin D, because we do think it's very safe. One of the lessons from VITAL was that 2,000 IUs a day was virtually free of adverse events over 5.3 years. It had a very good safety profile. So during a pandemic, why not recommend that everyone kind of ensure they're outdoors, getting some sun exposure, and being physically active, as well as maybe taking a supplement, 1,000, 2,000 IUs a day. I think that's quite reasonable. But to have conclusive evidence about causality, we need the randomized trials. So far, the randomized trials that have been done have been small. Some of them have been promising, some of them not. We're doing a trial right now called the Vitamin D and COVID-19 trial, VIVID, and we are planning to look at, or we're in the process of recruiting several hundred people enrolled already, and we hope to have close to 2,000 participants overall. We're looking at vitamin D supplementation started right after the diagnosis, or high dose supplementation, 10,000 IUs a day for 2 days as a loading dose, then 3,200 IUs a day for 4 weeks. Looking to see whether that will reduce severity of symptoms, risk of hospitalization, need for healthcare visits, and outcomes of that nature. And we hope to have the results toward the end of this year or early 2022. I do think these randomized trials are very important, but I do agree that recommendations should go out to the general public to avoid vitamin D deficiency, really at all times, but particularly during a pandemic when there is promising evidence for vitamin D, being of benefit. And there was the meta-analysis of acute respiratory infections that was published in the British Medical Journal in 2017 that suggested, if you look across the board at acute respiratory infections, vitamin D supplementation was associated with a significant 12% reduction and was of greatest benefit in those who were vitamin D deficient.
So along those kind of concepts, we actually did an intervention trial and took vitamin D deficient and insufficient adults and gave them either 600, 4,000, or 10,000 units a day. And we got their white blood cells at the beginning of the trial and at the end of the trial after 6 months, and asked the question, if you improve your vitamin D intake, what is its impact on gene expression in your immune cells? And the data were quite remarkable. On 600 units a day, even just 600, we saw about 150 genes being up and down regulated. 4,000 units a day, about 300. And on 10,000 units a day, where we saw no toxicity, up to 1,200 genes were being up and down regulated. So another question I think should be asked, and we have a study that's now been initiated and underway, is will improving vitamin D status improve immune response to the vaccine, right? Because we know that it's an immunomodulator. That's number one. Number two is it possible that if your vitamin D is sufficient or start taking vitamin D, that the long haul consequences of COVID could be significantly reduced? And so we have a study underway looking at this as well.
Yes, and we're also going to be looking at these questions in Vivid and some of our other cohorts where we have the information on the vitamin D status. But I think those are really important points. And Mike and I are collaborating on a project in Vital looking at gene expression and seeing if there is, a better gene expression profile in those who are randomized to vitamin D versus placebo.
One thing I'm seeing a lot in my clinical practice is after patients get COVID, there seems to be an acceleration in the progression of prediabetes to diabetes. So for instance, I will see a patient who has an A1C of 5.7 or 5.9, and then they get COVID and they see me a couple months after COVID and their A1C is 7.5. So I think that's something that needs to be investigated. But in the context of vitamin D, there is some data that vitamin D can help with that prevention of prediabetes to diabetes. Your thought on this data?
The D2D study, and they actually didn't find, very much like what Joanne found, much benefit in reducing risk of going from pre to full-blown type 2 diabetes. But they were also have the same issue. A lot of their subjects were vitamin D sufficient at the very beginning. So I think that when you're vitamin D sufficient and you're getting vitamin D, even if it may or may not have a little bit of a benefit, it dilutes the effect for those that were vitamin D deficient.
We actually did a meta-analysis of all of the randomized trials that have looked at progression from prediabetes to diabetes. And we are seeing a significant, about a 12% reduction overall. It's not large. However, there is a signal there that vitamin D supplementation does prevent progression to type 2 diabetes, especially if it's taken in a dose of 1,000 IUs a day or more. However, what was most interesting to us is there appears to be a modifying effect of body mass index, and this was found in the D2D trial as well, that vitamin D seemed to be most bioactive in those who were not in an obese BMI range. And I think this needs to be better understood. Those who had a body mass index less than 30 did have a significant, nearly 30%, I think it was 29% reduction in type 2 diabetes in the D2D trial with the 4,000 IUs a day if they were not in an obese BMI range. However, those above 30 didn't really have any reduction in risk. So there may be something about adiposity and the inflammatory state or other factors associated with adiposity that are counteracting some of the bioactivity of vitamin D supplementation. And if we understood this better, we might be able to make vitamin D supplementation of benefit to everyone, regardless of BMI levels. Some of it may relate to dilution and sequestering of vitamin D, and that could be just a dose-related effect. But I think it goes far beyond that because D2D tested 4,000 IUs a day, and they really did not see any benefit of the vitamin D in those with a BMI above 30, whereas they saw a very substantial benefit in those with a BMI below 30. And we're seeing this in VITAL for a number of outcomes, including total invasive cancer. So when we looked at those who started out with healthy weights, actually we looked at BMI less than 25, there was a statistically significant 24% reduction in the development of invasive cancer, which was our primary endpoint. But at the higher BMIs, we did not even see a signal for a reduction in cancer. So I do think, and this is something that Mike and I and his colleagues are going to be exploring further, whether obesity is affecting in any way the gene expression signaling, whether it's in any way affecting the bioactivity of vitamin D, and if so, what can be done to counter that?
Yeah, we even saw this in our publication for the COVID study out of our hospital. Those that were BMI greater than 30 had much less benefit, even though their 25-hydroxyvitamin D was the same as those that were normal weight. So you're absolutely right. There's a lot going on in obesity that we don't understand. And one possibility of being able to overcome all this is that we did a study recently that you may have seen, where we decided to give 25-hydroxyvitamin D to obese patients, to patients with gastric bypass surgery, as well as patients with fat malabsorption, and asked the question, if you're giving 25-hydroxyvitamin D, which is more water soluble, likely getting absorbed directly into the portal system rather than having to be formed into micelles and chylomicrons into the lymphatic system, can you give the same dose to an obese person and a normal weight person or a malabsorption patient? And at least from our initial data, we showed that the pharmacokinetics are identical in obese and normal weight and in patients with inflammatory bowel disease. So something that we could think about down the line is it would be really neat as physicians to be able to give one is good for all, that you don't have to worry about all these other issues and how to tailor their dose of vitamin D. It turns out that 25-hydroxy-D was available as a pharmaceutical back in the 1970s. And then just lost favor because they said, why spend money for that drug when you can get vitamin D? But now it's becoming available, even in Australia, as a supplement over the counter. And so I think over time, hopefully that will become available and will be a lot easier to use. And it'll be interesting then to see to do studies as to whether or not giving 25-hydroxy-D can even overcome the obesity issue associated with responsiveness.
I think this will be so important because I really do think one of the reasons why so many of the vitamin D supplementation trials using mostly D3, but also some with D2, have not shown a benefit in the overall study population is because of this interaction with body mass index. And in several of these trials, those who are at healthy weights or not in obese BMI range are seeing some benefit, even a substantial benefit from the vitamin D supplementation, but that's just not being seen in the higher BMI groups. So further exploring and delving into this issue, I think could provide such important information for making vitamin D supplementation benefits available to the entire population. And using 25-hydroxy-D could be a great approach to the problem.
Well, thank you both for your incredible insights. I want to conclude by getting recommendations from both of you on what you tell your patients today and what vitamin D levels you aim for.
So I certainly think that following the Endocrine Society practice guidelines is a reasonable approach. And they recommend for all adults, 1,500 to 2,000 units a day. And they recognize that if you're obese, you need 2 to 3 times more. For my patients, I typically have them on 3,000 to 5,000 units a day. For children, the recommendation is 600 to 1,000 units a day. And I think that that's very appropriate. Teenagers, I think, should be treated like adults, and they should be getting 1,500 to 2,000 units a day. And then finally, I personally take 6,000 units a day. My blood level, 72 nanograms per ml. I like for my patients to be in the preferred range recommended by the Endocrine Society of 40 to 60 nanograms per ml, and up to 100 is perfectly safe.
So I would say that the recommendations need to vary according to the health status of the person. And also during this pandemic, I would err on the side of recommending more vitamin D. So currently I would recommend, like even on a population-wide basis, 1,000, 2,000 IUs a day. In general, prior to the pandemic, and once we can get over the pandemic, I do think the Institute of Medicine guidelines are not that far off for a generally healthy population. The 600 to 800 IUs a day, but certainly taking 1,000 to 2,000 should be perfectly safe. And I don't think anyone who wants to hedge their bets and get up to 2,000 or even a little more should be cautioned against that. The Institute of Medicine did say to avoid more than 4,000 IUs a day. I don't think there's a lot of evidence that that's a dangerous dose, but it just hasn't been tested really long term to know whether taking 4,000, 5,000, 10,000 IUs a day for 5 years, 10 years, 15 years would really, the benefits would outweigh the risks. We don't know. Those trials haven't been done. That's why we kind of recommend that people stay more with a moderate dose, because there hasn't been strong evidence to date that getting above 2,000 IUs a day will be better than, getting above that would be any better than 1,000 to 2,000 IUs a day. But getting back to what Mike's saying, and Mike and I are both endocrinologists, so, we're going to be seeing patients who have bone health problems and endocrine problems, and there is always clinician latitude in adapting the dose of vitamin D to the patient's needs. Many patients will need much more than what I've just been talking about for a generally healthy population. Someone who has bone health problems, who's had a fracture, certainly giving them 4,000 IUs a day could be very, very reasonable. Someone with malabsorption or fat malabsorption or post-gastric bypass surgery, or someone who is on certain medications that interfere with vitamin D metabolism, there will be many patients in a clinical setting who will need more vitamin D. And I think clinicians should feel that their hands are not tied, that there is a lot of clinical discretion and clinical, latitude in deciding what is the best dose for their patient.
Well, thank you both for sharing your expertise. We have a lot of exciting clinical trial results to look forward to, and hopefully we can reconvene and discuss those trial results. Thank you both.
Thank you.
My pleasure. Have a delightful day.
You too. Great seeing you.